I can hear you.
Yeah.
So I'm here on the other lab, and I'm with Dr. Karl Chan, who you all know, APCTO, Dr. Chan Yu-ho from COMC, and Dr. Leap from Northern District Hospital. And I think you all know them. They've been APCTO fellows for a very long time. So we have another interesting case on this side, and I'm going to let Dr. Karl Chan, you can present the case for us, and Angel.
Okay, so our patient is 45 years old gentleman, got history of chest discomfort and hypertension dyslipidemia. So we performed a coronary angiogram a few months ago. We showed that there is a tight proximal RCA lesion, and also there is a LAD-CTO in the mid segment with some collateral. I'm going to explain that in the later time. And also there is a circumflex CTO. So we able to fix the RCA lesion with a single drug-eluting stent. And then the circumflex CTO has been treated with an anti-gray technique, which has been successfully treated. So I'm going to show you the angiogram. Today our target is the mid LAD CTO. So you can see that this is the angiogram from the right side, and the stent is still okay. And you can see there is a collateral coming off from the atrial branch supplying the distal LAD. So here comes to the left coronary angiogram. And you see that the CTO segment is right after the mid LAD in the distal LAD segment with a very juicy septal-septal collateral supplying the distal LAD. And from the spider wheel, the circumflex stenting for that CTO lesion is very nice. So should we have some discussion before we go on?
Yes,
yeah.
yes.
Okay.
So how will you guys manage this CTO?
Okay, maybe Dr. Ko, can you?
Dr.
I guess I will I was guided. I put a Y in the diagonal branch and then check the IVAS of the ostium of the middle LAD. Yeah, this is my current consideration. Thank you.
Dr. Yamamoto, would you make a comment?
Thank you. Good case. This case is a brand CTO proximal cap and ambiguous. So, and there is a large space proximal to the CTO entry. So the antegrade puncture is maybe difficult this case. So I first I was checked proximal cap, and under IVAS guidance using DLC, antegrade puncture will be performed. But after that, antegrade wiring could advance to the distal. I will use IVAS guide chip detection method, but antegrade wiring could be failed. I switched to the retrograde approach, and I use APCTO channel for retrograde approach, and finally I could reverse cut, or maybe the antegrade puncture still be difficult. Direct cross is one option under IVAS guidance.
Do we have a CT scan of this patient?
Yeah, this is important.
Yeah,
just in case that do you have
to
their
have a
CT
CT scan?
No,
before
he
the-
did not come with a CT scan, I think.
Okay, it would be very, very helpful. We're just looking at the pictures that you're playing at the moment, and we're just debating whether there's some antegrade channel, whether it be bridging or micro channel, or whether it's just overlap. If you play the angiogram, it's the previous one.
Yeah, maybe
Okay,
the IVAS should be pressed into the septal instead of the diagonal, because before after CT scan we can
The
realize
LAO
the
cranial.
root.
Can you see the angel, Scott?
Yeah.
Yeah, we can see the angel.
So now they're on the stop motion here. Okay. Now we can see that this route is a bridge or microchannel. We don't know.
Yeah, but do you see what we're looking at?
Yep.
Yep.
Yeah.
So
IVAS will tell us.
okay.
Yeah.
So I'll show you the IVAS.
So what I do is that I wide both the septal and also the diagonal. And then we have an IFAS pull from the diagonal side first to locate the proximal cap. So Eugene, could you help us to explain the IFAS?
Okay, so this is the IVUS from the diagonal. Can you see the diagonal? Can you see the IVUS?
Yeah.
Are they seeing the IVUS? Yes, okay. So I'm just playing it through at the moment.
From here?
I'm going to pause and show you the relevant
From
part.
where?
So
From the
this is
4 o'clock?
diagonal,
Yeah.
diagonal, and you can see here
Yeah.
we start to have a
I don't know.
Yeah, there.
little branch at the top, and then this at 4, 5 o'clock seems to have another joining it, but not clear, right?
But
Yeah.
from the wire, you can see that there's 2 wires. So we can tell that the proximal cap is unlikely branch off from the diagonal side. Because if you can see the proximal cap before you see the septal wire, then the proximal cap is in the diagonal side. But right now you can see the IFAS. You can see the you cannot locate the proximal cap clearly, and which is you see the septal wire earlier than the proximal cap. So that's why we then perform IFAS to the septal side.
Yeah. And I think this is, again, we saw the difference between using a lower frequency IVUS. You get more penetration in the far field. Obviously, the problem is that if you want to do real-time wiring and you're using the eagle eye, you need 8 French, right? So that's the
40, 40 around is much better.
So this is from septal, and you can see very clearly now, we can see the clear cap coming in. This is more distal. There we go.
More distal.
More distal, more distal, more distal. This is the cap. There you go.
Clearly we can see.
Yeah, and then
there's another one. I'll show you another one. This is the other one. You can see this cap. See?
From the
12 o'clock.
2 o'clock, right? Yeah.
12 o'clock.
Now is there?
Yeah,
One
there, 12
element.
o'clock. There.
Can you put dynamic review on there? Because sometimes you can just want to see whether there's any sort of flow or anything in it.
Red blood cell speckles.
Yeah, yeah. Looks soft.
I can't
looks
do that.
like
Hold on.
Hopefully.
Let me see.
Yeah, very difficult to confirm the speckles. Yeah.
Very difficult. Let me see if I can make
Yeah,
it.
I know. Yeah.
I need help with this IVUS now. Okay, let me see a better cap. Better cap. Dynamic review. Dynamic review. Help. I don't know the button for dynamic. There, okay.
Do you have IVUS guided view? No?
I'll move a little bit more. Okay, stop. Move a little bit more proximal. See if I can see. Oh, no, this is more distal. This is better. This is better. Dynamic review. Okay. No, can't see. Not convincing. No. Okay. So, what? So I think your suggestion now is you can see it from the septal. So I guess your opinion would be to do antegrade puncture under IVUS for this, right?
Yeah.
I have one question for you. This cap doesn't look difficult. It looks like you can antegrade puncture this. When you get down, how many of you would use 3D wiring of some sort to wire the distal, fluoroscopic?
So,
and
Dr.
how many would
Shibata,
just use traditional
so
wiring?
if you made progress, punctured a proximal cap, would you use 3D wiring to try and get true crossing?
Okay, thank you. If I can penetrate this LED CTO proximal cap, and after that, do I do the 3D wiring technique one or retrograde?
Correct.
Okay. Yeah, probably this CTO and LED CTO is not so long, and this I was showed that the proximal cap is a little bit more or less not so tough, not so calcium. Then it might be a good option to use the 3D wiring technique, I guess.
So I guess the question really is you're asking is the quality of the distal vessel, right? And I guess there's two things. If you make a proximal cap puncture and a low force or medium force wires making very easy progress, maybe 3D wiring is not required, right? But if you make the puncture and then there is considerable resistance, then probably 3D wiring is best because the distal target is relatively small, so it may be hard otherwise.
Okay, so Carl, what did we do?
So initially we would like to have show up the 3D wiring, but I think that because in order to have a more easy to appreciate the 3D wiring technique, my plan is put a retrograde wire in the distal RAD. So what I did is that I did a selective angle, and you can see that the septal collateral is quite good. It's quite big,
Yeah, looks
and
like
in fact
good.
there is
Yeah.
two channel, one in the big one, another one a very small one, the one below the big one. So initially I just want to put in the wire just for the easy discussion because we don't have to inject the contrast repeatedly. So what I did is that I just have a very brief wiring to the septal. To be honest, this channel is very easy to cross. This is only the start of the case of 5 minutes. So then we are able to cross the lower one. In fact, the lower one is better because the angle of attack is better. So you can see the wide field is really good. So although it doesn't that good, so I have another check. I'm sorry. This is the wire crossing angle. So it crossed easily, and then the rest is that I put have an angle check, make sure that the wire is in the distal RAD. Initially, I should stay here because we would like to have demonstrate the 3D wiring technique. But I just think that why don't we just put the retrograde microcatheter further so that we can have angiogram there. So what I did is that I used this high track microcatheter. There is some resistance here, and with some manipulation, I was able to push the high track beyond the distal RAG.
Okay.
And
we might stop you there because there's a lot that's happened here. And
okay, sorry.
Too fast.
No,
Sorry.
I think it's very debatable about how you should progress from here, right?
Yep.
Because it'd be interesting to see. I mean, I can foresee a number of problems.
Yep.
So maybe Dr. Matsuda, now we've got to this part, how would you progress the case, and what problems do you foresee?
Sorry, so retrograde. Yeah. So, so in these situations, anything is better. Maybe not so difficult situation. So maybe the retrograde microcatheter is a good pass into from the retrograde. So you should retrograde crossing with the Gladius EX. Direct crossings, maybe if you're lucky, maybe direct crossing is would be succeeded. So in this situation, I use the Gladius EX at first from retrograde.
Okay.
So I agree with Scott that this is not the usual approach because as we discussed before, the proximal cap is very likely to be a very tough cap. Yeah.
That's exactly.
So we may have to prepare the proximal anti-grade proximal cap preparation first. But indeed, the procedure is super smooth at this point. It's only around 1 to 2 minutes.
Okay. So I guess you've made a lot of progress, and I think this is a really important time to discuss the pros and cons of the approach. Because Sarah, you were saying?
Yeah, I'd probably like to try and make a bit more progress antegradely at this point, just because the antegrade cap it's still ambiguous for me, and I don't really kind of understand it angiographically, which is now how we're working. We've resolved our distal ambiguity because we've got a microcatheter and we've got good injections, but our target is, the septal antegradely. So I'd probably leave the wire there, retrograde, take the microcatheter and put a dual lumen over the septal and then try to make some progress antegradally, even if you just know you've got a bit more purchase in the mid LAD after the septal and diagonal. Because if you try, retrograde wiring here, I'm just concerned the diagonal's big and
So I guess, you could do direct crossing under IVUS guidance.
Yeah.
That's one.
This is a very simple technique, simple procedure.
Which is probably the safest way of doing it, but it'd be very important to confirm with IVUS that you're coming true to true with two, fairly significant branches. Yeah. The other question is, if you start antegrade, is, how do you manage the two systems in the one catheter? So do you keep with the one catheter and just use two low-profile microcatheters? That can cause problems. Or do you put a second guide and do ping-pong? So because, at least my experience with ipsilateral collaterals is that when you try and do everything with one guide, it generally becomes very difficult.
Generally, yeah.
Yeah, I see.
Yeah, difficult.
So I think
especially get the advanced microcatheter. Yeah.
Yeah, so I
Eugene?
think your points are very valid. I mean, the diagonal and the septal are big branches. So retrograde single crossing has that risk. If it's observed under IVUS, probably acceptable. But I think, I've been thinking more and more about 3D wiring. And I still think there's a good chance I can get antegrade. And now with the retrograde marker, I can get 3D wiring and get antegrade through. In which case, I can use the same guiding, get an antegrade, 3D wiring down to the distal, swap it out, get rid of the retrograde system, and carry on. So I think that may be the most efficient and safest way to do it.
Okay, so
did we do anything more, Karl?
Yeah, I agree that if we retrograde wire crossing, there is a risk that we may lose the major side branch, the diagonal branch. That's why in most of the case we should use IVUS guide, confirm that our retrograde wire is within true lumen before we do anything else. But I'm going to show you the angiogram when we did the septal IVUS. So this is the location of the proximal cap. You can see that there is a length going inside the septal before you go to the LAD. So the risk for the primary retrograde wiring is we're losing this small septal instead of losing the big diagonal branch. I think if the proximal cap is right at the diagonal branch, I may not do a retrograde direct wiring, because I just think that this one, I have some distance from the ostium of the septum. So we have some information before we can go into the true lumen. Yeah. So what we did is that we go back to the retrograde tip injection.
I think the other point is that actually doing, real-time wiring of the cap there would be very difficult because of the small caliber of the vessel, right? So when you had the IVUS there, there's
and
not...
you mean occupied the
space?
Yeah.
Occupy the space, so it then becomes very difficult when there's disease
and the
lumen's not big enough.
Yeah.
So having seen that, I too would go to direct retrograde crossing.
Yeah, retrograde crossing is the more simplified procedure, I think. Yeah, we know that have the risks losing the bifurcation, but actually just only that we lose the bifurcation with the septal is right.
But
yeah.
Also soft,
yes,
right?
yes.
Yeah, it looks like a soft tissue. There's no calcification.
So maybe we should do
even
that.
If the single, even if the single guide and using the ipsilateral collateral, and maybe this guide wire after that pass through the CCT region, maybe insertion that under some branches, maybe we can do the guide wire trapping using the branches. And for the insertion, the microcatheters.
So, yep. Thanks for your advice. So, you can see what we do is that we can see that the proximal cap is a little bit taper tip from this angiogram. So what we did is that just like what I mentioned, we try to have a brief attempt of the retrograde wiring.
Which wire did you use?
This one is UB3.
Okay.
Yeah, because there are some tip filling. So, and then we able to close to the proximal cap, just like the IVUS location. So, but the wire tip in this segment is a little bit fishy. Yeah, you can see that it's not that overlap. So what I did is that I stepped on Sydney on two wheel. You can see from the arrow cranial wheel, it seems that the retrograde wires go towards the left of the true lumen. So what we did is that we just have some wire redirection, and then we cross the wire to the LAG, the proximal LAG with a two-wheel confirmation. And then, so you can see that the wire is already, with the angiogram tracker, the wire is already on the proximal LAG. And then you can see the wire is in the aorta. So here's come to our next discussion. What should we do next? Because to be honest, at this moment, it's only around 10 minutes from the start of the case.
Too fast.
I think.
Yeah, too fast. Because I'm supposed to be broadcast in half past
But
one.
lots of discussion points.
Yeah,
right?
yeah.
So I think, part of this is the direct retrograde crossing with the UB3 is a lot safer because of the feel, right?
Yep.
The problem if you use a Conquest Pro or something like this, there's no feel. So you can be in subintimal and in plaque or in the wall and it will progress. Particularly if you have to use a high penetration force wire, you need to have the IVUS right there so you can see the wire going across before you sort of progress it. So that, and even with the UB3, I would probably try and have the IVUS, at the origin of the diagonal so I could see the wire coming back and ensure it was in the true lumen before I progressed it into the proximal LAD. I don't know about you.
Yeah. So actually, if we can set up the IVUS, is a more safer the procedure. And anyway, so this retrograde guide wire maneuverability is very poor and very difficult to control usually. And maybe this like intermittent diploid guide wire is very suitable for this situation. Yeah.
So
I think maybe we can, if we use the ping pong guide, left the diagonal branch inside too, and then go retrograde, and I can use IVUS in the diagonal branch or AAD to see, to real-time IVUS to visualize the wire pass in the
Okay,
AAD
you mean
true ping pong guide.
Another guide in the
Yeah, I will
for the
use ping pong
IVUS.
guide.
Yeah, okay.
Left the wire in the diagonal branch and go to retrograde. And if I retrograde anti the LAD, I think I can see the wire on IVUS, real-time IVUS, and that will be make me more happier or more comfortable to make sure that I will not lose the diagonal, because the diagonal is a very big branch, very, very big diagonal.
So I agree. But we're now in this position, and so we're very happy wire's going to cross, but it's actually quite a difficult position, right? So Dr. Shibata, you've got to this point. How would you progress from here?
You mean just now?
Yes.
After the retrograde wire goes up to the antegrade wire. Okay, in that case, well, actually I have less experience of the APCTO retrograde channel wiring, but in this case, maybe this wire is still UB3.
UB3, yep.
Okay, so if possible, the micro channel, I want to go up to the micro channel to the antegrade guiding with wire tracking into the antegrade guiding.
So you're going to put the wire into the same guide?
Well, or puncture the other one and the double guide, and the new guiding, the retrograde wire. I want to put the retrograde wire into the new guiding guider.
Dr. Ko, what would you do? How would you progress this case from this point?
Oh, using only one guide?
At your choice. This is what I'm asking you.
I will use two guides.
Two guides.
Two guides, one, and the retrograde wire enter another guide. not the retrograde guide. I will disengage the retrograde guide and then pass the wire into the new guide, integrate guide, and then trip in the wire and then do the microcatheter into the retrograde guide.
Yeah, looks like complex, but simplified.
Simpler.
I think.
It's more safe, I think,
more
for me.
safer.
I can be more comfortable.
I think the other important thing, right, is if we want to advance the retrograde microcatheter,
You cannot trip in.
the thing is that you need to be able to trap and
A trap and
because,
advance the
because if we just
the
push,
wire.
we
cannot push.
we can extend the pathway and we can rupture ipsilateral.
and too much the pushing.
By too much pushing.
Yeah.
So if we are sort of trying to control a little bit, it's better.
But in this time that we have the chance to performing the tip in.
Yes, I think I agree with you guys because Scott has made a very good point. This channel is a very small septal to septal. I don't want to push retrograde stuff. So I want to convert antegrade. Now, if I can convert antegrade with tip in with a single guide, I don't think I need a second guide because the antegrade goes in and we can swallow out to antegrade system. Now, as to checking with IVUS, that's difficult because now we have a wire, a microcatheter, and an IVUS is too much for 7 French. But what we
not
can
necessary now.
Not necessary because there's 2 things you can do. One is actually you can still get an IVUS and this microcatheter because the retrograde wire is not inside the guiding. There's still enough space to check it with IVUS if you wanted to. But it's going to be tight because you need a wire to track the IVUS. So the other thing you can do is you can put a C-on wire down, the LAD, and you can turn the wire and see if you can hit the retrograde wire. Because if you can hit the retrograde wire and show resistance to the C-on, then you're in the same lumen. And as long as you're in the same lumen above the diagonal, you're okay. So I think those would be the 2 conditions that I would consider tip in. Now, the other thing, of course, you can do angiogram. 2-view angiogram is actually quite reliable to see the retrograde position. So we have a 2-view angiogram that we can see the diagonal and the retrograde wire is clearly in an angiogram. Then I think we can try a tip in. If the tip in works, then we can convert to antegrade. And I think that will be the safest. I really don't want to push this retrograde channel. It's very small septal.
That's very easy to rupture.
That's my point of view.
We
So what did you do? You're up to date now.
Okay. So we totally agree that all the opinions, because the septal channel is quite small, we don't want to rupture the channel. And the problem is that if we want to advance the microcatheter, there is some resistance in the band. As I mentioned before, I need some force. So if we try to use ping pong guide, my concern is that although there is a protection with the microcatheter, there is still some chance of injury the septal channel. And then what we did is that since the procedure is quite smooth, so we have a lot of time. So we try to wire the retrograde wire to the same guiding. So we very easily just go inside the guiding. So and then the next step is that we did tip in. So we use the antegrade cross-apple access. So for the increase the chance of successful tip in, so we usually do it at the band of the guiding. So I pull back the antegrade cross-apple. You can see that right at the turn. And then I try to wire the cross-apple tip. You can see that it just tip in. It just go in.
Everything very easy for Karl today, huh?
Yeah, I mean,
not fair.
I mean, it's quite smooth. I mean, it's
very
right now
expert.
it's around 15 minutes. And then
I think one of the important parts of a tip-in, right, is the advantage you had here is that you just had that single short bend on the UB3, right? Once you have a bigger bend,
yes,
it is very hard to do a tip-in, right?
Yeah, another point I want to add why we use this method is that, to be honest, when I wire the CTO body with the UB3, I don't need any force. And I think that the plug is quite soft. I just like a workhorse wire, it just go through without much manipulation. So and then so what I did is that with the retrograde UB3 inside the antegrade cross-apple, you can see that you advance to the aortic arch. And then I drill the cross-sepal excess towards the CTO body. So you can see it's coming. You can see that it's crossing the proximal cap at the end of the furrow safe. And this is the another angle projection. I just step on furrow for you. And this is the arrow, I'm sorry, it's the AP cranial wheel, and the cross-sepal is go inside the CTO body. So I think this is the last angiogram we have. This is the real life.
So we want to know whether you can pass.
I think it already passed the proximal
critical.
cap, to be honest.
But the CTO?
I think should be, because I don't have much force when I drill the you can see that already crossed.
Yeah.
When I drill the I'm sorry, the UB3, I'm sorry. You can see the cross-sepal already crossed, furrow safe.
Oh, very fast, okay.
So you can see that the cross-sepal already crossed the CTO body. So what we should do, should we check the angle?
I don't think you need to check now. We should switch out for soft wires, antegrade and retrograde.
Okay.
Then check the channel for integrity.
我哋要個run through extra copy. So I pull back the 好啊，呢個走啦，走啲算啦，唔好走晒。呢度啦，係啊，少少。係咯，我要走翻出嚟，因為而家仲喺個街。係啊，仲喺入邊。So I pull back the retrograde wire outside the antegrade microcatheter, and then I advance a bit. Okay, here. Stop on. 我有個呢度有個 sorry.
But what wire is that?
So
this is the same UB3. So right now I'm passing the workhorse run through extra floppy through the you can see okay.
And
so here is the
anti-rate system.
Okay. But I want to change the retrograde wire to a soft wire too.
Sure.
Before we back it off, so that we have.
Should we go to the Shuo 03?
Yeah.
Shuo 03.
So you have a soft wire over the channel in case there's anything wrong with the channel.
Yeah.
Then we can still coil it.
Yeah, this is very good idea.
As we advance the antegrade microcatheter, we don't have any support. We just advance our antegrade microcatheter along the retrograde wire. So if the patient is not diabetic, if the plug is harder,
doesn't work.
It's not work.
No.
Because we have only retrograde wire into the antegrade guide. Integrated microcatheter. So the advance of the integrated microcatheter will not be so smooth.
No.
Because the plug is not hard in this case.
Usually,
so this way works.
Yeah.
You
but
want to
if the
get your
patient
backup
is
straight.
diabetic or the plug is harder, the integrated microcatheter will not advance so smoothly.
No.
Yeah, and usually in the anchor ballooning.
Yeah.
So totally agree. Yeah.
There are many methods to deal with this, and actually, Manos and I had a long discussion about this. And so I think there are various ways you can deal with this. One is you can increase the backup with a side branch anchor, or with a guide extension, or a guide extension with side branch anchor, which is very powerful backup. Second, you can increase the strength of the retrograde, the antegrade microcatheter. You can use a turnpike spiral, or you can use something that's got more penetration force. And third, you can put a wire in the antegrade that touches the retrograde wire, so that you have some wire to track the body over. So yes.
Is that still the UB3 retrograde? Not very good.
Huh?
Is that still UB3?
No.
No, we exchanged to Shuo 03.
03.
Okay.
This is Shuo 03. The UB3 already gone.
I'm happy now.
Okay, Shuo 03 is in the.
So that's the point I made, that you should switch out for a soft wire to check the channel.
可唔可以放大一格唔該？係25 fill size，唔係25。
But I think just guide injection is okay to check the channel, right? Because
I think I have to back off the microcatheter touch, but need to control the guiding. Because the guiding is going to suck in. 哇，好難搞。
This is joy of using one.
我睇埋個 guiding tip，做 Y tip 先。
Very complicated.
Yes, so this is one of the issues with doing single guide. But in this case, you can always push the antegrade corsair because it's in the CTO body. It's got quite a lot of push. Or you can put a third wire in the aortic cuff. So those will be very safe ways to allow you to back out the retrograde microcatheter without damaging the left main os.
Storm on, guy.
But I think Karl has done it already, right?
Yeah, not completely.
But it's out of the curves.
Yeah. Yeah.
It's,
Okay. Okay, storm on.
So
排
now
冰先
we
點
should,
㗎
yeah, now we should check before we leave the septal.
And just in case our step is there first, the checking their injury with their septal, and after that take out this septal system.
Yes.
And they put in a stent. Okay.
Yes.
3 steps.
Sounds easy, right, Wataru? Cross the CTO, check the IVUS, put in a stent. Very easy. Okay, channel looks intact.
Yeah, I don't think
good.
there is any problem.
So we should follow Wataru's advice and remove the retrograde gear, right?
Okay.
Yeah.
And then we
So
should
should
go
I?
antigrade. Yes,
Should I?
yes, yes.
Yeah, you can.
Remove the retrograde gear gently. It's a suo, so it'll come through without any problem, I think. So this is why you want to switch to a suo, because if you pull UB3 through a tortuous channel, you can damage it again. That's very nice. Good.
So I have to another check, should we?
Yes.
不如放翻第一格，點解 ECG 冇晒嘅？
照埋先，
我照多槍先，照多槍先。
照埋先。
Very
I'm
nice.
pretty sure that the channel is
Channel is
okay.
intact, so we can get
So
out.
I just get out,
哇，後少少。
and then the stuff, the rest is just like a PCI. 我哋要個
So, are there any questions, comments about this case? Otherwise, we can move back to the other case to see how they're doing.
It's
Yeah,
a
feel size
very, very nice demonstration, and very congratulations to the team. You made a difficult case look easy, very efficient. I think there are a lot of learning points in that. Maybe you want to summarize?
Thank you very much for showing the very nice demonstration. And maybe that you can do the simplify the CT or the procedure. And especially that you have luck. So I mean,
luck very important.
Success with ease.
Luck very important.
Yeah, luck is very important.
Skill, not so much.
Yeah.
Yeah, I know.
Okay.
And just in the insertion, the wire and the rotation, we can do that.
So we'll go across the other lab. We'll come back to see the final result in a moment. Yeah, we're online. Can you can you hear us? Yes.
Yes.
Too quick.
Clear.
So what we did is that, sorry, I need to go back. So here is the angiogram we left. After we balloon the CTO body, this is the angiogram after the balloon angioplasty to the CTO body, and we did and 冇掂嘅手上嚟。We did an IVUS to see the size of the vessels. So Eugene, should we
Yes,
pull
I'll
up
play the IVUS.
Yeah, IVUS.
This should be it. Actually, you have, this is the IVUS run through. You can see this perimedial brightness a little bit.
Yeah.
So a little bit shrunken the distal AD. This is full of
But
plaque.
unfortunately,
And you can see this is the bifurcation.
Yeah. Okay, thank you very much.
So I'll go back and play it once more because it's plays quite quickly. So this is distal. You can see the perimedial brightness, suggesting this is a little bit of shrinkage of the vessel. A lot of plaque, but we're true lumen. Here's the junction of that diagonal, very clear. And the proximal is not very diseased.
Can you just show us the junction of the diagonal?
Going down from proximal to distal, there we go.
Yeah.
Here.
Yeah. So it looks a little...
We can do this. Now I know how to do this.
See the tissue?
And from a suite to the simulacrum.
Yeah, so...
Yeah, looks like a disease.
Looks like there's some disruption. See that?
Well, this is okay, I think.
Keep distal.
Distal, there's a little bit. Proximal seems to connect very nicely here, right?
Yeah, just...
So distal, there seems to be a little bit of...
You mean there?
Okay.
Yeah, so...
Here, from here.
Yeah, it may be...
So we need to protect the diagonal.
Yeah, and it may be interesting to do a pullback from the diagonal.
to see. Okay.
Well, no, the issue is that the diagonal is important, right?
Yeah.
Yes, yes, it's a big diagonal.
And I don't think that anyone in the room would say that they were confident that there wasn't an issue at the origin of the diagonal.
Maybe not. Look, this is proximal and it's okay. This may be just the shadowing from.
Maybe.
Yeah, maybe
Yeah, I
from
don't think there's much
angiographically,
problem.
and there's no flap. Yeah.
No, I don't see anything. And maybe this is just the blood dropout from the shadow of the carina.
Could be.
You see, OCT would be better. So, what did we do next?
So since the angiogram, you can see that there's some pinching in the septal. So what we did is that we wired the septal, and then we balloon angioplasty the septal, and then we are planning to put in a stent with active transfer of plaque technique or gel balloon technique. So aiming that the proximal landing is right distal to the diagonal bifurcation. So we balloon the septal, and then we put in a 3-0 stent. So the right.
This is a very long stent. What is this?
Yeah.
This is Eucalymus stent.
How long is it?
It's a 3048.
Okay,
yeah.
48. Okay.
Okay.
Yeah, because the
So-
post-dilatation
so
limit is quite
just-
good to
guys-
the 40.
Guys,
Okay,
we must
sorry.
stop you there. We've got plenty of time, so
Yeah.
I think there's you're too fast.
Too fast.
Too fast.
Okay.
And leisurely we have the 40 minutes.
But I think there's important discussion here because actually, not being a huge DCB guy, but actually this is the case I would consider a DCB because because there's a long segment.
That's what I was saying.
Not
Not
a
I say very long stent.
very long, some disease, but the plaque is soft.
Yes,
And,
and this is a 50 years old
Yeah,
male.
and I think rather than put a long stent in here, I would cut it, and I would see how it looked, and then DEB it. So maybe comments from the panel: who would stent,
Yeah.
and who would DCB?
Yeah.
I will choose brand therapy combination between stent and DCB. A stent for CTO culprit region and distal for DCB.
Yeah, and actually from the I was finding the distal part is we can see the high echoic media band. So maybe there are the later and the automatically enlarged.
Yeah.
Yeah, consider this is a 50 years old male, and then we can cross intraplaque. And frequently in the mid LED there is a myocardial breachings. So I thought it's better to use a DCB, and then there is a bifurcation there.
So that would be my personal. Sarah, what would you do?
Given the fact that you're going so fast here, I would also IVUS the diagonal just purely just to take that box off to make sure the diagonal looks okay. And just DCB over the CTO segment, and the rest of the distal vessel is going to grow. It's definitely not. I probably wouldn't put a 48 millimeter stent in, with all due respect. I'd just DCB the CTO.
So you DCB without any stenting?
No.
I'd probably cut it and DCB it, and there's lots of operators and lots of them in the room probably now that do a lot more DCB than me, and I don't think there's any downside to it if you prepare it properly.
Okay, well, we might take a poll of the room, okay? So who would, you've got three options, right? Cut and DCB only, if everything looks good. A hybrid approach, where you put a short stent in, a CTO segment, and then DCB distally, or long stent. So who's for the long stent? Okay, who's for the hybrid approach? Okay, who's for the DCB only approach?
Hi.
Okay, so it's a draw, but it's a draw between DCB only and hybrid.
It's a draw.
You have already put the long stent in.
So You mean equal number of people long stent and hybrid and DCB only?
No one for the long stent.
No one for long stent, and it's equal for hybrid and DCB. Okay, so when there's an equal, what I usually do is look at the imaging more carefully. So if you look at the imaging, and I'm scrolling it, can you see the IVUS?
Not at the
Not yet.
moment. Yeah.
Now,
Okay, can we show the IVUS?
Yeah, now we can see there.
Okay, so we're going down proximal. You can see this part of the vessel before the diagonal is a huge vessel. It's a 5-0 vessel, okay? As we go past the diagonal, this is still very heavy plaque, but still a 3-0 vessel, okay? So this part is still quite big, okay? This is almost 3.5, okay? So stents will do very well in this segment. As you get past here, okay, the vessel size drops, but so does the plaque volume, okay? And here I'm also looking at anything outside. Is there a myocardial bridge outside? The myocardial bridge will mean that I want to stop before that. So I think down here, okay, actually the plaque volume is not large, and you're starting to get this slight brightness, the PMB. So I would, if I was doing IVUS guided, I would probably put about half the length of stent from like the ostium of the diagonal here down to around here, where the plaque volume suddenly decreases and this perimedial band starts coming up. Because I think this will be around, you know, this is 18 or 19 millimeters stent. And then the distal, I would DCB. So I think I would use, I'm beginning to try to use the imaging to guide the hybrid and how long. But I must confess, I'm still not entirely comfortable with doing just DCB for a CTO segment. That is still, I'm struggling with it. Because I have some successful case and I have some failed case. So I have cases that come back, reocclude, and but the next CTO is very easy, so it's not interesting and it's boring. So I don't want to do that.
But the interesting thing is, like, and you know, I'm not a big proponent of DCB, particularly in large vessels, because of the absence of data. But actually, Colm Hanrati has been doing a lot of DCB in CTO, and he was showing me his results, and some of them are very interesting. So the key thing is obviously if there's a subintimal course, you can't DCB, right? So it has to be intimal. And then I think here, one of the advantages of preparing this, and after your initial preparation, just fairly low pressure, a small balloon, they look pretty good, right? Is that, if you did preparation and it looked good, and you did DCB, and I guess it depends on reimbursement and things like that. At the moment, what we're doing is we're bringing these people back in 3 months, right? And at that point, you can say, oh, it looks great. We don't need to do anything more. Or if it doesn't look so good, then usually you can put a bigger, more focal stent in. So that's my strategy. What about you?
Yeah, so we have the same problem here because in Hong Kong, some of the patients have funding from the government, in which case they will be brought back. And some patients, like these two we have today, are self-funded. And then we tend to not bring them back because of the cost issue, basically.
Yeah, and for me, basically I would like to put the stent, the origin and the CTO part. But for the distal part, and if it looks like a shrinkage, and if we can see the medium high echoic band, it's maybe giving the small band with the low atmosphere and giving the DCB. I prefer to perform in the hybrid. But actually, that depends on the CT length and the lung warp. Yeah.
May I ask what stent that you've chosen?
So this is the Eucalyptus stent. It's I don't think you have it in Japan yet. It's a company called Eucatech, which is a German company. It was acquired by Oberschnitz recently. So this is a 65 millimeter thin strut stent with 9 crowns with huge side branch opening. So it's ideal for side branch disease too. And it's deliverable like all the modern thin strut stents. So I think it's coming to other countries soon because Oberschnitz used to have the combo stent, but now they've acquired this company Eucatech and they've got this. So it's a Solarimus eluting stent with the absorbable polymer.
哇，好散條話，
好散啊條啊，我諗你換個條。
孭翻第一格啊，唔該。
So I don't know. Do you have it in New Zealand? Scott has everything in New Zealand.
咁你呢條哇好難。
我諗應該都係
No, 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 we
Yeah,
don't.
we
Not
have
yet,
in
not yet.
Taiwan. We have a eucalyptus stand.
So
可能
let's
要
go back to
調。
Karl. Let's tell us what you're doing.
Available.
So we
more than 400
post
cases.
dilatate the stand under the IFAS guided. Indeed, the reason we pick a long stand because that we did balloon angioplasty to the CTO body, and you can see from the angiogram there is a lot of recoiling.
Show us the recoil.
I guess you didn't use a cutting or a scoring balloon.
Yeah, we should. Yeah, but
And you didn't do long inflations, I imagine.
yep, you're right. Yeah. So, but anyway, yeah. So we put in stand there, and then we did the post-dilatation under the IFAS guided with a 3O balloon. And here is the
But your
angiogram.
septal is still not here. Oh, it
Yeah,
comes
but
back very
you
late.
have retrograde
Retrograde filling.
filling from
Retrograde, we
the
can see.
distal septal. I think for cosmetic reason we can open up the septal, but I don't think that should have any ischemia. So we maybe have a brief attempt to whether we can wire the septal and then just open up that there.
Probably not worth it, right?
Yeah, I agree. Yeah, it's just for cosmetic.
Probably
yeah.
not worth it. You have good retrograde.
Yeah,
right?
if the distal septal is just supplying the septal myocardium. Yeah.
The key is, does the patient have chest pain or ECG changes?
No.
Right? And if there's no chest pain or ECG changes, do nothing. Would anyone do anything for the septal? It's unanimous. Leave it alone.
You know, Canvas is not there. Canvas always says get every single branch. So no objection. So you also did an IFAS?
Every single major branch.
Yeah, we did. So we did an IFAS.
Can we show the IVUS?
And the study formula. Okay, just this part of the stand. Yeah.
Okay.
Yeah.
Okay.
So probably can do 3-5, right? Just below the diagonal.
Yeah, we can.
Yeah, to get a better result because it was 3-5 beforehand, right?
Yeah, but the reason I stop here is that I initially want to wire the septal before we do the 3-5.
Okay.
But if we opt for not doing the septal, then we can just post-dilate with 3-5.
Yeah, just the proximal bit maybe.
Yeah, shall we? We just go for 3-5.
Okay.
Yeah.
3-5 NC Sapphire 3-5
It looks, at least on this view, it looks pretty expanded, right?
Yeah, just the IVUS is a little bit under. Just
Yeah,
gently.
the angiographically looks
That's a
reasonably
very short
okay.
segment. Actually, a very short segment. That's 3-5.
Yeah, but the problem is that you landed
hold
in
on,
the
hold on.
bifurcation.
Yeah, sure.
And you're in plaque.
Hold
you
on,
use
hold on. We have
3-5,
different opinion.
you may get a proximal edge dissection.
You are right, actually, Scott. I'm looking at this
Yeah.
more, and the segment is so short. Maybe it's really not worth it because you might dissect
now we
this,
can
Yeah,
keep
I
the
think
and
so.
then we're in
Yeah.
trouble.
We don't need it.
You know what
maybe.
they say? Perfection is the enemy of good.
Yep, angiographic
So-
is quite nice.
Okay.
Yeah.
So
Quite
Scott, you
nice.
finish
We
the
can
case for
keep
us.
the
Okay, we
publication.
not
Thank
do
you
any
very
more.
much, Scott.
Thank you very much for this side. I want to thank Karl and Yo and Leap and the cath lab staff for us to doing this. And thank you for watching this case. I'll be back in the other room very soon. But Alan will do most of the talking.
Thank you very much for the advice.
Congratulations.
Yeah. Thank you.
Thank you very
Thank you.
much.